Hello everybody and welcome to our module on antiplatelet drugs. Recall that the two ingredients for a blood clot or a thrombus are activated platelets and fibrin, which comes from the coagulation cascade. And there are many diseases where thrombus forms and is harmful to the patient, and in these disorders we try to block the formation of thrombus, and we can do that by either blocking the formation of fibrin or blocking the function of activated platelets. The drugs that block the formation of fibrin are called anticoagulants, and we'll talk about those in another module. In this module, I'm going to focus on drugs that block the function of activated platelets, and those are called the antiplatelets. There's also a special class of drugs called the thrombolytics. These are clot-busting drugs used in special unique situations, and I'll also talk about these in the anticoagulant module. Antiplatelet drugs are very easy to understand if you know the substances that can activate platelets. So thromboxane from arachidonic acid is a very powerful platelet activator. So many drugs block formation of thromboxane. ADP is a powerful activator of platelets. So there's a class of drugs that blocks ADP. And then finally, a low cyclic AMP level inside of platelets causes the platelet to become activated. This is the way that ADP works. So drugs which raise the cyclic AMP level will function as antiplatelets. And then finally, activated platelets express an active form of the receptor 2B3A on their surface. So there is one class of drugs that blocks this receptor on the surface of platelets. So let's start by talking about aspirin. Aspirin blocks the formation of thromboxane A2, which is a very powerful activator of platelets. The way it does this is through inhibition of the enzyme cyclooxygenase. The way the body makes thromboxane A2 is by beginning with lipids in the cell membranes. There is an enzyme in many cells in the body called phospholipase A2, which can pull lipids from the cell membranes and synthesize molecules of arachidonic acid. Arachidonic acid can then be converted by the enzyme cyclooxygenase into thromboxane A2, and that is where aspirin exerts its effect. There are two forms of cyclooxygenase found in the body. One's called COX-1, the other's called COX-2. They're both found in platelets, and aspirin inhibits both of these enzymes. By doing this, as I said on the last slide, it blunts the conversion of arachidonic acid to thromboxane A2 and decreases platelet activity. Now you may know that aspirin is also a pain reliever, and this has to do with the fact that in addition to blocking formation of thromboxane, aspirin also inhibits the production of prostaglandins. Thromboxanes and prostaglandins are examples of signaling molecules called eicosanoids. Leukotrienes are also an example of an eicosanoid. All of these signaling molecules are derived from arachidonic acid. There's an enzyme called lipoxygenase, which converts arachidonic acid into leukotrienes, and then the cyclooxygenase enzyme converts arachidonic acid into thromboxanes, but also prostaglandins. And because aspirin blunts the formation of prostaglandins, it also has effects related to pain and inflammation, in addition to the platelet inhibition effects, which are all mediated through thromboxanes. This slide lists some of the effects of eicosanoids derived from arachidonic acid via cyclooxygenase. One of the most important is prostaglandin E2. Prostaglandin E2 mediates many of the effects we associate with inflammation, things like redness and edema, fever, and pain. All of these are mediated by prostaglandin E2, and this is why aspirin functions as a pain reliever and anti-inflammatory. Prostaglandin E2 also mediates renal vasodilation, especially of the afferent arteriole, and this is why patients who take aspirin can have negative effects on their kidneys. Prostaglandins E2 and I2 are both important for protecting the GI mucosa, and this is the reason that aspirin can have a negative effect on the GI mucosa. And then, as we talked about before, thromboxane A2 is derived from arachidonic acid via cyclooxygenase, and thromboxane A2 is important for platelet activation. NSAIDs are non-steroidal anti-inflammatory drugs. These are drugs like ibuprofen, naproxen, and some of the others I've listed on the screen. I talk about these in more detail in one of the immunology modules, but I want to point out here that aspirin is technically a non-steroidal anti-inflammatory drug. What's unique about aspirin is that it irreversibly inhibits COX-1 and COX-2, where the other NSAIDs reversibly inhibit COX-1 and COX-2. For this reason, aspirin is the preferred antiplatelet drug because it will decrease platelet activity for the lifetime of the platelet, about 7 to 10 days. The other drugs, since they are reversible inhibitors, can potentially be bumped out of the way if there is significant platelet activation. All of the NSAIDs, however, inhibit cyclooxygenase and decrease the level of thromboxane A2, and therefore they're all associated with bleeding, including aspirin, and they all reduce pain and inflammation via lowering the amount of prostaglandin synthesis. The most common antiplatelet uses of aspirin are in coronary disease and stroke. In both conditions, it's used in the acute phase and also for prevention. Patients having an acute myocardial infarction or unstable angina are always administered aspirin. It's also given long-term for secondary prevention of recurrent coronary disease. The same is true for stroke. It's often given as acute therapy in ischemic stroke, and it's also used as a secondary preventative measure. The main adverse effect of aspirin is bleeding. By lowering thromboxane A2 levels, it makes it harder for platelets to activate, and therefore patients are at greater risk of bleeding. In addition, aspirin, like all NSAIDs, can potentially cause gastritis or ulcer. That's because cyclooxygenase is important for synthesizing prostaglandins that maintain the GI mucosa. A rare side effect of aspirin is tinnitus, or ringing in the ear. This is caused by salicylate. One of the metabolites of aspirin is salicylic acid, or salicylate. It can alter cochlear nerve function. This is a very rare side effect, but it does sometimes come up on board exams. It usually occurs when patients receive very high dosages of aspirin, and it resolves with discontinuation of the drug. A very serious adverse effect of aspirin is Reye's syndrome. This is a syndrome that involves liver failure and encephalopathy, and it's associated with aspirin use in children. I've shown you a picture of this kid on the screen here to remind you of Reye's syndrome and its association with aspirin. Because of the risk of Reye's syndrome, aspirin is generally not used in children. The one exception is Kawasaki disease, which is a vasculitis syndrome. It can be life-threatening in children, and it responds very well to aspirin, and for this reason aspirin is given in this rare condition despite the potential risk of Reye's syndrome. The next class of antiplatelet drugs are the thienopyridines. These are drugs like ticlopidine, clopidogrel, and prasugrel. They all have a chemical structure similar to ticlopidines, which is shown on the screen. All of these drugs irreversibly inhibit the receptor P2Y12 found on platelets. This receptor mediates the effects of ADP. So by blocking this receptor, these drugs block the effect of ADP on platelets. They're sometimes referred to as ADP blocking drugs. You can use these drugs in patients who are allergic to aspirin. They're also added to aspirin therapy often for prevention of myocardial infarction or stroke. Their major adverse effect is bleeding by blunting the activation of platelets. There's also a rare, dangerous adverse effect of this class of drugs, and that is the syndrome TTP. TTP is thrombotic thrombocytopenic purpura. I talk about this in much greater detail in the module on platelet bleeding disorders, but for our purposes here, you should know that this syndrome is associated with all of the thienopyridine drugs. Its strongest association is with ticlopidine, and this is one of the reasons that ticlopidine is not used much anymore, but it's also been reported among patients taking clopidogrel or prasugrel. The syndrome results in a severe thrombocytopenia, also a microangiopathic hemolytic anemia, and finally neurologic abnormalities. It's caused by a deficiency of an enzyme called ADAMTS13. The mechanism by which this enzyme becomes deficient in patients taking thienopyridines is not entirely clear. In many cases, antibodies to this enzyme have been discovered, but in other cases, antibodies haven't been found. But whatever the mechanism, this enzyme becomes deficient in patients taking these drugs, and that's what leads to TTP. Ticagrelor also blocks the P2Y12 receptor and blocks the effects of ADP. However, it has a different chemical structure from the thienopyridines. It is not a thienopyridine. It is called a cyclopentyltriazole pyrimidine, or a CPTP. And what's different about this drug is that it reversibly blocks the P2Y12 receptor. It's been touted as a drug that has a quicker washout than the thienopyridines. Because its effect is reversible, it may wash out of the body quickly, and you don't have to wait as long for the effect to go away if you stop ticagrelor. It's also not associated with TTP, which is another advantage it has over the thienopyridines. Its one unique side effect is dyspnea. Many patients who take this drug complain of shortness of breath. The mechanism is unclear, and there's some evidence that this may be a neurological sensation of dyspnea in absence of any pulmonary or cardiac problem. But whatever the mechanism, a number of patients do report that they feel more short of breath when taking this drug. The next class of antiplatelet drugs are the phosphodiesterase or PDE inhibitors. These are drugs that are really very rarely used for their antiplatelet effects. Both of the drugs in this class inhibit phosphodiesterase 3 in platelets. Phosphodiesterase is responsible for breaking down cyclic AMP. So when you inhibit this enzyme, you will raise the level of cyclic AMP, and this will lower the amount of platelet activation. There are two drugs in this class. One's called dipyrimidol, the other's called cilostazol. So dipyrimidol is a PDE3 inhibitor that inhibits platelet activation. It also has another effect. It blocks adenosine uptake by cells. Adenosine is a vasodilator, so when you block the uptake of adenosine by cells, you raise adenosine levels, and this can lead to vasodilation, which is responsible for some of the other uses of dipyrimidol besides antiplatelet. It's also responsible for many of the side effects. Dipyrimidol is used together with aspirin sometimes for stroke prevention. This is for its antiplatelet effects. It's also sometimes used in chemical cardiac stress testing, and this is for its vasodilator properties. In patients who are unable to walk on a treadmill for a cardiac stress test, vasodilators can be used to induce coronary steal, and I talk about this in more detail in the cardiology modules. Cilostazol is a PDE3 inhibitor that inhibits platelet activation, and it does this by raising the cyclic AMP level in platelets. However, it also raises the cyclic AMP level in vascular smooth muscle, and this leads to vasodilation. This drug is rarely used for its antiplatelet effects. However, it is often used in peripheral arterial disease. It's used in this situation because it's a vasodilator and it can increase blood flow to the lower extremities and decrease symptoms of claudication. If you can remember that the two drugs in this class have vasodilation properties, then it's easy to recognize their side effects because many of the side effects are related to vasodilation. Patients taking either of these drugs can develop a headache from meningeal vasodilation, they can develop flushing, and they can also develop hypotension. All of this is related to the vasodilation effects of both drugs. Our final class of antiplatelet drugs are the 2B3A receptor blocking drugs. There are three drugs in this class: abciximab, eptifibatide, and tirofiban. All of them bind and block to the 2B3A receptor on platelets. Abciximab is a fragment of an antibody that binds to the receptor. Eptifibatide and tirofiban are large molecules like I've shown on the screen. All of these drugs are IV drugs. You will only see them used in the hospital. They're only administered for brief periods of time. They're typically used in patients having acute coronary syndromes or in patients who are undergoing coronary stenting. The main adverse effect of these drugs is bleeding, just like with all antiplatelet drugs. However, there is one unique side effect, and that is thrombocytopenia. This can occur within hours of administration. The mechanism is poorly understood. There is a hypothesis that we may have preformed antibodies that are stimulated by these drugs, but whatever the mechanism, you have to monitor the platelet count after administration because thrombocytopenia is an important side effect of these drugs, and when it develops, you usually need to stop the drug. So I'll finish with this summary slide just reminding you of the different classes of drugs and how they each block a different pathway to platelet activation and platelet plug formation. Aspirin blocks the formation of thromboxane A2. The ADP blocking drugs block the activity of ADP, and the phosphodiesterase inhibitors all raise the level of cyclic AMP in platelets. And then finally, the 2B3A receptors are unique. They don't block platelet activation, but once the platelet becomes activated, they block its ability to adhere to other platelets. And that concludes our module on antiplatelet drugs.